Thank you, Ajay, for the kind invitation. It's a great pleasure to be amongst all of you. We've heard some amazing talks on the diabetic maculopathy, diabetic retinopathy, and all these new concepts which are coming in relation to the lasers as well as the advances. I'll just briefly take you over some of the surgical indications for diabetic macular edema. These are my financial disclosures. The gross indications for surgery where the diabetic macular edema is concerned is in case you have a subhyaloid hemorrhage which is blocking the macula, you cannot assess and you need to do a surgery for that. Apart from that, you either have a vitreomacular traction, which is a mechanical condition, a thick hyaloid causing a traction, or a epiretinal membrane, or it could be a chronic non-responsive edema of some sort that would be an indication for surgery. So when you talk of a subhyaloid hemorrhage, basically you need to clear the media. So there you just identify the plane of the hyaloid, remove all the liquefied blood which is underlying the hyaloid, and then identify all the bleeders, and which allows you to assess the macula, and you could either give an injection or lasers depending on whatever the macular underlying pathology is about. And also control the PDR component by doing a PRP as well as diathermizing the bleeders as we identify them. Sometimes the identification of the hyaloid can be a problem, like a case like this, again a subhyaloid hemorrhage, and after clearing the vitreous, we go and identify the hyaloid and start to peel, but sheet moves hyaloid, but it's actually just splitting the cortical vitreous, and it's not the true hyaloid because the underlying tissue is still encompassed by the true hyaloid which is there. So after that, you clear up some more vitreous and come back and identify the tube plane, and then you can see that the underlying blood gets liquefied and becomes accessible to your cutter, and then you can remove the blood and then identify what's happening on the macula beneath. You can see there is edema here, there is some strias which suggest there has been a chronicity of this blood lying there and has caused some stress on the hyaloid leading to these strias over there. So now once you have ruled out these mechanical indications and you've identified on the OCT that there is no thick hyaloid, it's only an unresponsive edema, you also need to rule out ischemic maculopathy before you do a surgical maneuver for chronic non-responders of some sort. So for that, I think the best way to look at is angiography. You look at the capillary non-perfusion zones or the foveal avascular zone more importantly, and you can identify whether it's healthy or not. And if there is a gross ischemia, then of course, no matter what surgery you do or you think it's a chronic non-responsive edema, it will not help that indication. So one must be clear that what you're tackling is either a traction-based situation or a true non-responder. So if you have a traction, you go ahead and remove the traction. It could be a simple vitreomacular traction which can be removed, or it could be these spanning sheets of hyaloid or membranes which could be there, which today with the new generation of cutters, we can go and easily cut using the cutter instead of trying to use the forceps and peeling these situations. These are just some examples of the spanning tractions and epiretinal membranes which are coming with a long-standing duration of these proliferations and sheets which come up. So one could use multiple maneuvers either with the use of a cutter itself or use adjunct forceps and to remove the membranes which are spanning in these areas, and then free the macula from any kind of underlying traction which is there. So these are some examples of traction which have been relieved with the surgical indications. This is again showing you a case where there is a very gross traction just temporal to the fovea. There is some thick tissue which is adherent temporal to the fovea apart from some of the other proliferations. So your aim is to free the macula from that traction, and you first take care of all the peripheral areas which are adherent to the hyaloid as well as the proliferations, and once you slowly segment them, relieve them of the traction which they cause by just their presence as in a bridging traction, and wherever there is a bleeding you need to go and stop it and control it. So here you see that after removing all that traction, because there was a stiff adhesion in here, we also try and remove the ILM from this area because it would also help relieve some of the traction which has been there because of the chronicity of that membrane which was present at that stage. So once you have a high mag view, you can know if you need to do anything more or not in these situations. This is again a case where there is spanning traction over the macula, and here after cutting some of the peripheral areas of adhesions, you come into the central part, and here we use the technique of the proportional reflux, where the cutter expels some of the fluid and helps you create planes between the retina and the underlying retina and the membrane overlying. So here you see that we've insinuated the cutter port between the retina and the membrane, and then press the proportional reflux, which allows some fluid to come out and create a plane very passively. You can see some egress of this tissue which has come from the tubings, which tells you that we are pressing on the foot switch with proportional reflux. So it very passively allows you to create planes just using the cutter instead of using any other instruments. So slowly you can keep on negotiating that and create small segmented areas, and then take them away and just keep small stumps which can be diathermized and removed eventually. And then, as we said, that the non-traction cystoid edema, which is not responding to that, surgery is done for that also. And many times we might not be able to pick up a very spanning attached membrane, while when you are working on a high mag during surgery, you can actually see that there is a membrane sheet, which sometimes, just because the foveal contour is not disturbed too much, we don't realize there is a membrane over it. But on surgery, you can go and identify these membranes and remove, and at times the edema would respond. And at the end of these surgeries, it's a good thing to add an anti-VEGF or an Ozurdex, whatever one feels comfortable, because the edema would finally respond after you remove the mechanical traction with one of these modalities. This is a very chronic cystoid edema which led to a small hole in the center, and here as you see, there is some hyaloidal adhesions which are also there. So again, very carefully, so as not to increase the size of the hole, because it's very, very brittle, very friable retina because of the chronicity which is there in this case, and one has to be careful with such cases. They will not gain too much vision, but the relief of traction would lead to a decrease in the overall scotoma in these cases. And lastly, again, a case of a chronic non-responsive edema. You can see how extensively this patient has been lasered and has been complaining of visual loss, and you see this strias of a membrane which is spanning over the foveal area. And the patient has been lasered very often in the past, but obviously his main problem has now come out of this central visual distortion because of being a non-responder. So there's a thick membrane which has come off, and after that we identify the underlying ILM, which is thickened also, and then remove that. So first the membrane comes off, and then the ILM, and at the end of surgery one would give an injection to help reduce the bulk of edema in these cases. So these are just a few examples of surgical indications for diabetic macular edema. Thank you very much.
Thanks, Manish.